about pretext. That's exactly what I'm talking about. That anticipation of what the results might mean, how you should think about it going in. So, do you think that there's widespread understanding in the ordering community, given what you previously said about any of us being able to order, about being able to access such written material and give it to patients?
Well, I don't actually know what happens now after the study has been completed. I mean, during the, I'll tell you more about that. I'm not sure. I mean, the Centre for Genetics Education. I just need to correct myself here. The Centre for Genetics Education, which is a statewide service funded by New South Wales Health, they are basically printing and disseminating the brochure.
And it's about to be on Evicure.
Right.
Sorry, we had a...
Look, I had a broadly based question and they've got to be answered in the next section. I thought we're at the end, so I'll wait.
Okay. And Phil, breast surgeon extraordinaire at the back. Phil?
So, Bettina, on one of the slides of your studies, you showed that that people were making treatment decisions based on the presence of various unknown pathological significance, which is, as you mentioned, is potentially quite a problem. And I guess it's somewhat highlighted by what happens in the States, of course, where there's almost an epidemic of contralateral prostatic mastectomies of patients with breast cancer who do not have any increased risk. So, do you have any information about how in that study, how many people made significant changes to their treatment decision, such as prophylactic surgery, which in the main was unnecessary?
We didn't actually compare the group receiving variants of unknown significance with the other two groups, carriers and those where no mutation was identified. So we don't have any data on that. We did an analysis looking at carriers versus the rest, but because of the power issues we had, we couldn't really explore the reaction of those who received a variant of unknown significance.
So, Lesley, if I can just answer that, Phil, in Australia it hasn't been the issue that it is in the States.
Absolutely.
So
that's reinforced, I think, America is a more medicalised system and a private system more so than here, which I think partially explains why there is that difference. But this, hopefully, might be a problem here if a lot more of this genetic testing is done. We find many mutations, we don't know what they mean, and then they end up creating patients being very distressed and making poor decisions.
Yes, that's why the Evicure guidelines recommend that they be seen by a family cancer clinic who is very experienced in communicating such a complex testing result.
And I think that while we're talking about a group based in a tertiary centre like this where we can provide good educational opportunities, the issue is those practitioners, surgeons, oncologists, non-genetic specialists who don't have that benefit of that reinforcement of being able to say, if you find a VUS, a variant of uncertain significance, refer it on. Okay, let's move on to the next section. Are there any further questions? No.
Okay. So the next section is, what are the issues for health professionals of mainstreaming? What do non-genetic specialists need to know? We've already touched upon that. Just to summarize, again, specialists need high-level genetic literacy and communication skills to provide pre-test genetic counselling, to communicate about the likelihood of a mutation being found, the implications for relatives, and of course explaining variants of unknown significance. Many studies have shown that non-genetics specialists, including medical oncologists, have insufficient knowledge of genetics, that they are mostly ill-prepared to counsel patients both pre- and post-genetic testing and report unmet educational needs. Non-genetic specialists report difficulties in genetic family history taking and risk communication, and you can see the publications supporting these findings at the bottom. Specialists have also been shown to misinterpret test results, which could lead to incorrect management. Further, they provide lack of adherence to guideline-based practices regarding BRCA1 and 2 testing, which may result in direct harm to patients and their family members, as well as increased cost to health services. Here, a recent Australian needs assessment of the workforce shows a lack of genomics education in the Australian medical training curriculum. It also highlights a need for continuing education targeted to different groups of health professionals. So there's an urgent need for genetic literacy and communication skills to enhance to make sure that there's optimal translation of genetic, clinical and research findings into mainstream healthcare. Genetic literacy and communication skills are a complementary set of proficiency, where genetic literacy includes knowledge of the difference between somatic and germline mutations, knowledge of indications for having particular germline genetic tests, including a tumor genomic profiling test, or tumor tests, and knowledge of the different clinical implications between pathogenic variants and variants of uncertain significance. Communication skills include skills for pre-test counseling, as well as conveying some of the complex genetic testing results to patients and their family members. What are the consequences of ineffective communication in the genetic testing setting? We have quite a few studies that have looked at that issue, and basically, unless specialists receive education and training in genetic testing and literacy, their genetic care of individual patients may be unhelpful or possibly even harmful. This is what these studies support. For example, if very sensitive information is conveyed inappropriately, this could affect the decision to proceed with genetic testing, the patient's uptake of known prevention and early detection for themselves, and communicating results appropriately to their relatives. Misinterpretation of variants of uncertain significance, and we've just discussed that issue, may result in patients undergoing inappropriate preventative surgery. Poor communication also unnecessarily increases distress for patients when they receive genomic testing results. What are some of the other consequences of ineffective communication? In general, ineffective communication impairs specialists' ability to assess and manage patients' physical symptoms and to detect distress. Cancer specialists report a lack of communication skills training is a major contributing factor to stress, lack of job satisfaction, lack of confidence when dealing with patient problems, and so-called burnout. The quality of the clinical communication also influences patient satisfaction, compliance with medications, and clinical and psychological outcomes. Poor communication is also associated with higher rates of litigation and malpractice claims. The adverse impact of clinicians' communication deficits is likely to be exacerbated in the genetic testing context, where clinicians frequently need to obtain informed consent, communicate complex testing results, and discuss emotionally charged topics, such as the significance of genetic testing results for their relatives. Another approach to address, one approach to address barriers in implementing mainstreaming might be to use a behavior change and implementation science approach, as Janet Long and Natalie Taylor, two experts in clinician behavior, have done in this study. And I'm aware that some of you were involved in the study. By way of background, patients undergoing surgery for bowel cancer now have a routine screening test to assess their genetic predisposition to this and other cancers. That is part of Lynch syndrome, so-called Lynch syndrome. A result indicating a high risk would trigger referral to a genetic clinic for diagnostic testing, information and management. and appropriate management of Lynch syndrome lowers morbidity and mortality from cancer for patients and their family, but the referral rates are low, as this study by Robin Ward et al. Showed, which demonstrated that only just over half, 54%, of patients with colorectal cancer with a high likelihood of Lynch syndrome were not referred. So 54% were not referred for genetic testing, despite indicators recommending referral. Therefore, Janet Long and Natalie Taylor's study aim to address barriers in implementing mainstreaming that might be used to effect change. Now, just very briefly, the results from Jan and Natalie's study. The baseline referral rates were 80%, 4 out of 5 from 71 screened patients in Hospital A, and 8%, 1 out of 14 from 113 patients in Hospital B. So basically, the studies were tiny. It's really just more of a pilot study. As part of the study design, the implementation science design, 15 interventions were proposed, including clarification of pathology reports, education, introduction of e-referrals, inclusion of genetic status in documentation, and pathology process increased the accuracy of screening, but the referral rate remained low, with 46% at Hospital A and 9% at Hospital B. So although the study did not find statistically significant results, most likely due to the tiny numbers of Lynch syndrome, it's a very rare condition, and nonetheless the study deepened our understanding of barriers to referral and approaches to low frequency conditions such as Lynch syndrome, and also it resulted in a number of methods and solutions that can be addressed to address low referral rates.
Any questions? Do we have any colorectal surgeons in the audience? No?
Perhaps David can answer. He's a colorectal oncologist.
Just thinking about that, we anticipate that mainstreaming under Medicare may be expanded to cover colorectal cancer, whereas at the moment it's only for breast and ovarian. How do you think that's going to go down with our colorectal surgical cohort?
So, interestingly, I suspect that the surgeons are thinking about it more than the medical oncologists, because I think that might come up in the interviews long before we see them to talk about adjuvant therapy. I still think that the knowledge about the availability of the test is not widely known amongst the clinical practitioners who could be ordering it. The knowledge about the presence of written materials that you could access to discuss with patients is not known, nor the fact that they provide comfort. That's not known either. These are really important issues that need, as part of the rollout of availability, you would almost think that the people who approved the funding would have worked out a clinical pathway to support the ordering of those tests, rather than just said, it's available, hope you find out, good luck. So it's kind of interesting, but maybe Phil Crow could tell us a bit about how he and his colleagues thought about it when they heard it was available for breast.
Phil?
I think most of us are reasonably confident in dealing with all these issues. I guess, as you indicated, we're very lucky here. If we're faced with a more complex genetic problem, we can send it to you. Or at least get on the phone and say, what should we do here? So I think in centres like this, these things can be introduced, I think, reasonably seamlessly. My concern is that a lot of patients present to private surgeons outside a major teaching hospital with the genetic service, how do they manage this issue? And I think that's a bit of that's something that needs to be addressed.
I I'm cognizant of the time moving on, and I just want to take advantage of, we've got Edwin Kirk here from New South Wales Health Pathology, and I really wanted to take advantage of him being here to say, to ask him, as there is more Medicare coverage and more non-genetic specialists referring patients for genetic testing, what impact is this going to have on our laboratory services?
Well, I mean, even without that, we're seeing a huge increase in the number of genetic tests that are ordered, and as Tina said, the costs are falling, and that's what's driving it. So, I mean, I'm sure most people in the room will be aware that there have been technological advances that mean that we can do very extensive testing for much less, and the trend is continuing. And I think that's what's driving a lot of the ordering that we're seeing, even before the introduction of many Medicare items. And the process by which those get allocated is haphazard at best, but there are more and more in the pipeline, and we're expecting to see the referral lines continue to do this. So what impact's going to have? We're drowning. And presumably we'll drown more.
What I'm hearing is that our funders, whether they be state or federal, are not really keeping up with genetics demand in the laboratory any more than what they're keeping up with in the provision of clinical services for those, because the more testing we do, even though the threshold is lower, the more people we're going to identify that will need to come to a genetic service and whose relatives will come. So what I'm hearing is that I think we're getting a clinical demand long before it's being met by our funders.
Yeah, but to be fair, I mean, you'd have to be pretty resilient to have prepared for this, because the lag time for training is years, and this stuff is happening on a much shorter time scale. So certainly with the New South Wales Health Pathology, there's awareness of the issue, there's a willingness to deal with it, but you need the people, you can't make it anything else.
Okay, so going on to training, we'll now talk about one initiative that Bettina's conducted.
As part of that study, we tried to answer the question of whether it is possible for non-genetics oncology health professions to implement mainstreaming in the ovarian cancer setting. We undertook a study, here are the other investigators and contributors to the study. The aims of the study were to deliver training to upskill non-genetic specialists and nurses who often have the task of getting informed consent delegated by oncologists, to upskill them for pre-test genetic counselling for patients affected with cancer, with ovarian cancer, to provide informed consent for BRCA 1 and 2 testing. The study aimed to assess oncology health professionals and familial cancer clinic genetics professionals, and to undertake an audit of familial cancer clinics in order to ascertain the effectiveness of the training initiative in increasing oncology health professionals' perceived skills and confidence in offering testing, the perceived barriers to successful implementation of mainstreaming, and the extent to which women who were offered genetic testing actually met national guidelines for genetic testing. These are also called FAQ guidelines, and they are shown here. What are these FAQ BRCA 1 and 2 genetic testing guidelines? Here they are. The slide shows the criteria that were assessed in the study, and they are directly taken from these FAQ guidelines. So it's basically a number of groups. First of all, individuals with high-grade non-mucinous epithelial ovarian fallopian tube or peritoneal cancer, provided they're diagnosed 70 years or younger, or where there is a family history of breast ovarian cancer, so that's where age doesn't come into it at all, or they meet the MBS criteria that we talked about earlier, i.e. they have relapsed ovarian cancer that previously responded to platinum therapy. And finally, individuals with a personal and or family history of breast and or ovarian cancer in a population with a common founder mutation. So that this in Australia this would be the Ashkenazi Jewish population. The URL for the FAQ guidelines, for those of you who are not familiar with them. Now, we already talked about this a little bit, who to refer to familial cancer clinics. Now, we've already said the second point here, carriers of a pathogenic variant or those with a variant of unknown significance or family history. But the first one, the first category would be patients where specialists do not feel sufficiently skilled to provide adequate pre- and post-testing. And finally, the last point, those with a personal and or family history of cancer suggestive of an inherited syndrome who do not meet MBS criteria. So someone with pancreatic cancer, for example, with relatives with breast and or ovarian cancer would fall into that category. Here's the outline of the design of the study. Basically, we delivered training. Training was delivered through familial cancer clinics at hospital sites associated with the respective familial cancer clinic. Surveys were completed by the oncology health professionals immediately before training, and then again 12 months following training. And the familial cancer clinic staff also completed questionnaires 12 months following training. Each of the oncology health professionals was given a folder to support the training process. It included a flow chart, and it included test requests form to allow feeding communication with familial cancer clinics regarding test results and eligibility, and also copies of patient education leaflets, which are also, by the way, now that the study has concluded, available through the Centre of Genetics Education, which I mentioned earlier. At both baseline and the 12-month follow-up, oncology health professions completed a scale validated by Natalie Taylor to assess perceived barriers to successful implementation of mainstreaming. This slide just shows the domains associated with this particular measure. We also collected data at the family cancer clinic, where for each patient for whom genetic testing had been ordered, the familial cancer clinic staff or one delegated member of the clinic completed a questionnaire for each patient regarding the eligibility of testing according to national guidelines, FAQ guidelines, did the patient meet the guidelines or not, frequency of contact with the FCC, the familial cancer clinic, and by the oncology health professional and the patient, the proportion of information provided on the test request form. We were interested in whether there was much missing information that had to be chased up, and also the time that was spent by the familial cancer clinic staff in chasing up that missing information. Results: 14 familial cancer clinics across Australasia participated. This is all but one, actually. Training was delivered to 29 public and private hospitals. A total of 42 workshops or sessions were conducted. A total of 185 oncology health professionals were trained. 157 oncology health professionals completed baseline questionnaires. The response rate wasn't optimal, but it's very challenging in our experience to get oncology health professionals to complete questionnaires. So unfortunately, we only had 79 that had completed both baseline and follow-up, the 12-month follow-up questionnaire. Here, the sociodemographic characteristics. I just want to briefly highlight that the majority of participants, about 3/4, more than 3/4, female. About 43% were medical oncologists. Here, a comparison of the results from the baseline questionnaire in particular. At the 12-month follow-up, oncology health professionals said that 54% said that they always or nearly always refer patients who meet the FAQ guidelines. The measure of perceived barriers to successful implementation of mainstream that I mentioned earlier showed a significant decrease, scores meaning more barriers, so it actually showed less barriers in successfully implementing mainstreaming at 12 months. So that's what we had hypothesized. In terms of, there's one question we included for oncology health professionals. Has the introduction of mainstreaming of genetic testing for ovarian cancer impacted on your usual workload? 53% said that it had no impact. On the next slide, we asked the same question of the Familial Cancer Clinic staff, and they said, a very similar percentage said, no, actually, 52 said that it had slightly decreased, which is what we expected. We expected a decrease in time commitments. So, in terms of the percentage of tests ordered that met FAQ guideline criteria, 273 mainstreaming tests were ordered. 93% of these met FAQ guidelines. The number of Familial Cancer Clinic appointments that were required or that took place, 13% related to patients who had a Familial Cancer Clinic appointment because they carried a pathogenic variant. 5% were seen because they carried an unclassified variant. 16% were seen in the context of a significant family history. So in conclusion, this was demonstrated a successful implementation of training. It was carried out at a very large scale, including almost all familial cancer clinics across the countries and the associated hospital sites. It showed an increased number of patients without a pathogenic variant or a variant of unknown significance or a strong family history who did not need an additional clinic appointment at a time when they're likely to be overwhelmed because they've just been diagnosed with ovarian cancer. And an increased number of patients not requiring highly skilled familial cancer clinic staff. Here's an acknowledgement of funding body.
Thank you, Bettina. We've just about run out of time, but I think one person for whom I really would like to have an opportunity to give some feedback, particularly in light of that study that showed that of 273 women having genetic testing, only 79 of them had to be seen by a familial cancer service, as opposed to previously, if they'd have had clinical testing, they would have all had pre-test counselling at a genetic service. And that's Rachel Williams, our senior genetic counsellor. Rachel, how do you think mainstreaming is going to have the impact on familial cancer services, and what's your experience?
Yeah, well, I think through the study, we certainly noticed a decrease. It wasn't a significantly huge decrease because ovarian cancer patients only represent a small number of the overall referrals. But quite often the nature of our campus is that the women are having treatment for such a long time, we tend to go to them on the day that they come to us, as opposed to being able to slot them into our normal streams where we have a normal clinic. And so I think the genetic counselling team certainly noticed a decrease in that, we need to go there out of session and attend to this quite urgently. What was apparent once the study finished and we had a couple of staff changes and absences of usual staff and so on, we had a little influx of patients, and suddenly we started getting those Thursday calls and those Monday calls because of the PARP inhibitor impact for treatment. And this suddenly had a bit more of an urgent nature where previously it wasn't. So it's a shift in medical practice as well as time as well. But from our clinical perspective, it did add a lot more pressure to us of having to find someone available. We're short-staffed at the moment, so it had a significant impact there as well. And I think during the study too, there's probably only one or two notable women who, even though they almost got mainstream because they had significant anxiety issues, that they were then sent through. So it worked very well from our perspective there, and we weren't seeing any undue anxiety elevation post results. and so from our point of view, it was quite successful.
Unfortunately, we do have to draw to a close, but are there any questions? I know Bettina had some further slides to present on some strategies